Thank you for joining us for this month's program, Parkinson's Journey program that we host every month in partnership with the ANOVA Parkinson's and Movement Disorder Center, the IPMDC. If you want to see more of what they're doing, you can go to their website at ipmdc.org. That's actually where the recording is going to be housed and the recordings of all the previous programs. I'm joined by the lovely Josefa Domingos, a physiotherapist from Portugal. She's been specializing in Parkinson's for more than 20 years. And I'm John Dean. I'm a speech-language pathologist, and I also specialize in Parkinson's since about 2007. So today's topic is going to be the impact of posture on communication, eating, and swallowing in Parkinson's. And we're going to show how it's a very common symptom, but we're going to show how it kind of globally affects a lot of areas. So we'll begin by talking about the impact of posture on communication, eating, and swallowing, those three areas of speech-language pathology. And then we'll also talk about treatment strategies and ways to reduce impact. And we'll start at the very beginning, a very good place to start, which is going to be the impact. We know that Parkinson's may lead to a lot of, or exacerbate a lot of these postural issues. It's something that is very common among people living with Parkinson's. And why that is not always as clear as it could be. And that's a lot of Parkinson's. Sometimes things are there as a sequela, as a part of a problem that we see, but we don't necessarily say, this is caused by this, neurotransmitter or that neurotransmitter. What we do notice is that there's a loss of what we call positional awareness, where people are maybe settling in or maybe focusing on something else, and they start losing kind of their thoughts about how they're sitting. Maybe they're sitting on one side or another. The muscle stiffness and the rigidity is a big factor here, and it's something that is part of the key components of Parkinson's. One of the hallmark characteristics is that rigidity, which means muscle stiffness. And while it can be in the elbow or the knee or the ankle or one of the joints is where you might have seen it first, it's also possible to have it all along the trunk, and that can certainly make things a little more forward-leaning. That term they use is kyphosis, so you can have that kyphotic posture. Probably this is where Josefa was talking last month, but it's also possibly why people have so much lower back pain in Parkinson's.
It's very common. It's very common for people to mention, why am I bending to the right side or the left side? Now I find myself bending more to this side. So I think there's a place here for obviously the asymmetry that exists in Parkinson. And so what you have is just basically muscles that are overworking and others that are working less. And so by that asymmetry on its own, it will obviously, if we don't train it and not aware of it, it can lead to these type of complications. So it's also a factor that blends in here.
That's a great point, too, is about the global side of that. And that's kind of what we deal with when we're doing some of the breath and voice stuff in the beginning of our voice, speech, and communication program that we do on Tuesdays. And it's exactly dealing with that chronic shortening, tightening of those musculature. And then on top of that, you can have a specific diagnosis of a dystonia, which kind of is the abnormal tightening of muscles, abnormal activity of muscles. And it can be very focal. And then you can even have it affecting like around the neck, and you can get kind of a torticollis where you get someone with that, or you can have a specific dystonia like a Pisa syndrome where someone leans on one side, and that means that it's literally like the Leaning Tower of Pisa. That's how they named it, and exactly that.
Let me just share an optimistic view of it, which is that is considered a complication, right? So it's considered rare to occur, those extreme situations. But the natural changes of posture, of the flexion of the head, that will be more common. And even if we age, as we aging, it also is part of aging. But just to make sure that it might be severe situations that are associated to rare complications.
Very much so, and I think that's a very important point, because the general postural stuff is very amenable to the exercises that we're going to talk about in the way we address it. I think I've encountered someone with really severe torticollis a half dozen times. Very, very rare. Not that common. So we're pieces in for that. You see it every now and then. It's not a hallmark. It's not a key feature. We do notice too in individuals that have what we call axial, which means midline issues, and those are people that tend to not have tremor as their primary, but more postural instability as their primary presentation. They'll have more of these postural issues. They'll also have more balance deficits, and those are tied together because The posture changes also mean that you're putting yourself kind of out of your natural balance. You're moving your center of gravity out of position. And then those people also deal with quite a number of swallowing problems. Drooling is very common, and the drooling will actually be more prominent because of that reason. And then they'll also have more frequent cognitive changes. They'll have more issues. And we'll get into why that is in a minute here. But we notice that for people that are dealing with postural instability, gait disturbance, or PIGD, a presentation. As we're looking at it, we wonder why something might show up in a verbal space or a communication space when it's tied up posture. And if you want to think about it, we're all communicating, we're talking. I'm using very good posture now because I'm on camera and I'm talking about it, so I'm even a little more aware of it. And so when you're thinking about that, everything is using gravity, and we're using approaches that we can use to make sure we have clear speech. So if you're, like I said, you're one of our classes, we work a lot on being upright so that you have good air support and you're able to do that. And if you don't have that, then all of a sudden what's going to happen is that you're going to be causing some mechanical issues. As you're leaning forward, now all of a sudden, instead of using my lips and my teeth and my tongue, all the articulators, if I'm leaning forward, now I have some weight associated with that. Now I have to use muscle to kind of make those things work more properly instead of being able to work the way that they were designed or intended when we were developing over time as humans. And then that breath support is a really key one because I think it's something that we don't recognize enough in that if you don't have enough air, you're never going to have enough sound, because the way that we produce sound in the healthy way is when we get a column of air, it comes through the vocal folds and those vibrate and then we shape that in sound. And if you don't have that proper column of air, you're going to actually compensate by squeezing at the vocal fold levels. And if you've ever been in a situation where it's too loud and, a lot of noise around and you're having to shout and you're doing that, you're actually getting that kind of tight sound, and it's actually you squeezing the vocal folds. I always make this metaphor of I'm watering the garden and I need to get to some plants across the yard, and I put my thumb over the edge of that. Well, I can do that. The water will get there, but it's coming out with such force, it's actually not healthy. It's going to, whatever plants it hits are going to get obliterated. And so what you really want to do is turn the water up, and that's kind of the same thing with this breath support. And then we mentioned about drooling before, but there was an interesting bit of research by a speech language pathologist, actually at the University where Josefa did her PhD. This was much earlier, and she actually did study on drooling and Parkinson's. And she noticed not only that people with Parkinson's don't actually have more saliva in their mouth, they're not producing more drool or saliva, but they're just not managing it very much. And that's not a problem if you're upright and you have good posture, because you still have this last line of defense. But once you start having people with a forward-leaning, that kyphotic, that forward-leaning posture, your last level of defense is now lost. And now if you have some saliva that's been building up somewhere along the lines, it's probably going to escape. Where if you're upright, hopefully you'll manage that saliva more actively. But in the absence of that management, then you'll actually be able to at least have your head upright enough that it won't fall out. It won't get to you. It'll probably catch you when you start to speak and you really don't realize that you had a saliva and you're getting ready to speak, and all of a sudden you end up coughing a little bit because you have your saliva going down the wrong track. I don't know which one's preferable for the other, but it is.
There's a question in the chat if you want to address it.
Oh, very good. Let me start with it here. Is there a relationship between PD, drooling, and excessive dry mouth? And I would say that I don't believe that there is much of a relationship as far as those two things. Those both can happen, but for different reasons. When you're talking about drooling and Parkinson's, it's 100% awareness. It's managing the saliva that we do in the background. Just like we blink a certain amount, and in people with Parkinson's, we notice that they blink less, and it's just a matter of not actively tracking that. Now, the dry mouth that happens, it's more often caused by medications, and not many medications in Parkinson's cause it, but there are some, but often it's other medications that maybe are part of other things that you're addressing that can cause that. So anything that could be slowing your system down a little bit, maybe to help you sleep or to work on anxiety or to address tremor, that's where it crosses over in Parkinson's. Those kind of medications, like anticholinergic medications or benzodiazepine kind of medications for pain, or for anxiety, those would be where you might have some dry mouth. And some certain pain medications could also cause that dry mouth. So I don't suspect that those two are related. If you're having a dry mouth issues, it's worth asking your doctor. Most doctors I know, and I certainly know Dr. Falconer, love to de-prescribe. They love to go through and say, is this necessary? Do we need this? Like spring cleaning, they'll be happy to talk about it with you. Okay, would tremors in the jaw be related to drooling? And again, yes and no, in the sense that I'll say that tremors in the jaw happen for sure. And actually, Dr. Oken just put a highly recent publication that was showing kind of overflow of issues from the motor parts of Parkinson's affecting speech and mouth. But I would say that, again, drooling, it's its own separate issue. The way that we typically address it, well, the way we used to address it when I first started is we would work together and I would have a little timer and we would be in my clinic and we would remind ourselves every time we hear the little beep from the timer, it's time to swallow. And then we set the timer for 2 minutes. That app is still out there. Swallow Pump's available, whatever, if you want to do that. But I have to say that in maybe the past 5 or 6 years, the botulinum toxins have gotten better, and there's one that's actually FDA approved for drooling called Ciamin. It was actually listening into one of Dr. Falconer's lectures that kind of got my attention to that because it's pretty effective and you don't have to do any of the work. So it's almost like taking a pill. You get the shot of the Botox, the Ciamin, the botulinum toxin, and then it addresses it for up to maybe 3 months. Takes maybe a week to come into full action, and then after that. And so I would say that, again, you could address the drooling separately, and then I would say the tremors are probably more medication related. And again, something that's probably very much related to the Parkinson's. You might even notice that when your medications are working, that the tremors are disappearing for that reason. Yeah, and someone's mentioning the botulinum toxin works well. I'll say this, that sometimes people might have to give it a couple tries. But then if you find a place that a physician it works, and again, a good movement disorder specialist knows they're just really good at it now, because I think it's really come a long way in the past decade or more. Then you can go back and do it as many times as you need to. Sometimes it does wear off a little bit and you don't get quite the benefit that you got the very first one, but it's still quite efficacious, and they can actually add other targets. In Europe, they used to do it in multiple places. They used to do it in sublingual glands as well as in the parotids, and that actually caused more dry mouth than we liked, but now they've refined that. So it's much better now. I didn't mean to talk about drooling so much, but it is something that's real, and it is something where if your posture is impaired and you have a drooling problem, then your drooling problem is probably not going to be coughing on the saliva as you get ready to speak. It's probably going to be something that you're going to be visibly trying to manage. Yeah, there's someone here. I'm just going to answer this question because it's an important one, and I think it's one that I would definitely get a referral for. More and more, I cough when eating. Sometimes I can tell it's food stuck in my throat, but more often I can't tell if that's the problem. Is this a Parkinson's symptom? And I will say that coughing at mealtimes is a kind of a hallmark symptom, a real indication of probably a swallowing problem, and something that you should get a referral from your doctor to a speech language pathologist and get an evaluation, because they can probably identify it's a very common problem in Parkinson's, so it's worth addressing, and the treatment can be very effective. Now, if you're saying you can feel their food in your throat and that's coughing, and there's times when you can't feel the food in your throat, then I start wondering, and this is what your evaluation with the speech therapist would help you on mass, is there could be some reflux, and that reflux could be causing irritation, and that's a very common thing, and it's another thing to talk about with the doctor. So if you go to the SLP and you rule out, you fix the swallowing as much as you can, you're still having this issue, then I start looking at dietary causes. Reflux is probably 3 times as more common in people with Parkinson's than it is in the general population, and there are medications and diet stuff you can do about it. So we talked about the mechanical side of this, where your posture puts everything out here. You know, your head is pretty heavy. Once you start moving it forward, now you're using a lot of energy and weight to hold that, where it'd be much better if you're more perfectly upright. Same for all the structures, where you rely on a lot of gravity to help move things, and also good seal. So when I'm swallowing, my tongue comes up against the back of my front teeth, and I make a good air seal, and we use that pneumatic pressure, that air pressure, kind of like those old tubes that would move things around office buildings or libraries. Same thing, we push the food that way, and if you're a little bit out of position and you're not as strong as you could be, you'll have a leak there and you won't have that pressure. So that's the mechanical side of how posture can get into it. But then if we're also leaning forward, now all of a sudden I'm not making full eye contact with you. I'm looking at the top part of it. So I've lost about 2/3 of the space there. And that means that you're not able, as my communication partner, to pull what's meant information from that eye contact. We use it quite a bit to indicate like turn taking and agreement and what we're talking about, looking at something like that. And then as the person with Parkinson's, if you're taking this in now, you're losing a lot of the upper part of the seeing. So you can't see as well and you can't see peripherally as well. And it makes it harder for you to communicate. And the reason why that matters, I mean, on the one hand, it just makes it more work. But if something's happening here and it's peripheral and your posture is keeping you from seeing it properly or taking it in and processing that information, it might look on paper like you're forgot or you're not aware or you're not cognitively with it. It's like, no, that's not it at all. It's like if a tree falls in the wood and no one's there to hear it, then, that's the same issue here. It's like if something happened out here and you didn't see it, it's not that you forgot it or, you're not paying attention. It's that it's not part of your intake. And that's why it can be difficult. Also has a lot of issues with the head nodding because, again, it's very difficult to do this with your head forward. I'm trying to demonstrate. I'm not sure how. I guess I can see myself on camera. And it's just you lose a lot of the things that you would do non-verbally. And then another thing, and I think we figured a lot of this out during COVID, but you'd be surprised at how much information that we get with lip reading. So I know you can hear me, and I know that we're all listening. We all have our computers turned up. But even just taking this a little bit out of here, now I'm blocking a sound a little bit, but I'm also making it more difficult. And if I'm also quiet a little bit, I'm talking, all of a sudden you've taken a very important component of what we use to communicate properly out of the mix. And then in my last one, and I always say this in class, but for people who aren't in that class, if I'm here and I'm leaning forward, I'm now aiming my audio signal to someone's sternum or their belly button, or it depends on how far you're leaning. And it's much better for everybody if you bring it up here and my audio comes to my ears. And so it all ties together at why you want to have this better upright posture, because it improves your communication that way.
I was going to add in that it obviously impacts one of the common complaints that I can't really turn my head to one side or to the other, which really limits the space that you are analyzing. And so obviously this will also have an impact on balance and how comfortable you feel in a standing position, because you can't really turn your head fast. But I would just highlight, so how do we improve something that becoming aware of it? So the goal of us sharing this is not to depress anyone. It's just like, if we are aware of it, then we can more likely be able to act on it. And I think the easiest, I would say, tip that people usually say is, I look at the sky. It's just, it's an example of a strategy that people use to understand where I want my head. If I look at the ceiling, okay, then I can feel that comfort, recovering that comfort of me feeling the pain of the stress of the muscles that are having the head forward. Okay, so everyone, let's look at the sky. Good one.
Yeah.
You mean the ceiling?
Yes.
I should have some guys up there.
Yeah, but you can feel immediately the relief, right?
For sure. And probably some of the exercises you do for that. I'm going to stay here and come to the next part of it and just mention that this is less defined in the literature, but it's certainly something that we observe, and it's something actually Josefa notices in classes. Like, if people seem like they're getting too quiet, then that usually means that we need to kind of activate. If you're in a position where you're kind of slumped forward like this and you're not taking as much information in visually, it does seem to have an impact on sleepiness. And so if you are a person that tends to sit down in a nice chair and get that kind of warm feeling that comes through there and you're asleep pretty quickly, posture will have an influence on that. And, I think I'm fibbing from Josefa, but her first solution probably to have you stand, right? But at a bare minimum, if you're in an environment where that's not as feasible, just having a more upright posture immediately changes that desire to kind of fall asleep and reduces that around your awareness of your surroundings.
I said, say, push yourself away from the chair and maybe put a pillow on the low back. And so that means it's automatically doing that for you so that you can keep attentive to a conversation that might be happening. But if you put your back on the chair and you're already dealing with sleepiness, that's asking for it.
We have this one Ames chair, and I know that it's like, I'm going to read some research in this chair. It's like, no, I'm not. I'm going to take a nap with some research in my hands in this chair. It's like, I know it's going to happen if I'm doing something that's brain intensive in a posture that doesn't really work for alertness. It's going to get us all, and it's Parkinson's or not. This last thing is more an animal study, so I want to be careful about overstating this, but cortisol is kind of like a fight or flight kind of neurochemical, and it's something that we notice in that people when they're in these submissive positions in that kind of situation, that they actually seem to have more cortisol, and that increases your anxiety, and that can also influence your ability to attend. Because if you're anxious about something, it interferes with how well you're listening and what you're looking at, and that can be part of it. And it's kind of an evolutionary kind of approach where they're saying, it's like if you think about animals that are in submissive positions or animals that are feeling like prey, that's kind of where the thought comes here. There were some interesting studies on this in the past, but actually when they went back to them, it wasn't as clear. And that's why I'm being a little bit careful about the way I say that. But I do think there is some common kind of the same thing with breathing. Breathing in through your mouth, it can actually raise your cortisol too. And again, it's evolutionary. Every time you're breathing through your mouth in the wild, 100,000 years ago, it's when you're being chased by something. So it's like, that's why it fits in there. But the other stuff is more mechanical and straightforward, and more importantly directed towards people living with Parkinson's. Now, when we talk about eating, it's very much the same kind of thing we're talking about here. So like, you're eating your food, you take your bites, you have your food in the mouth. And so if I'm here and I have something that's over here on one of the sides here, that really makes a difference. The gravity we mentioned, the lip seal. Even airway protection, meaning that when we swallow, there's an air pathway in the front and there's a food pathway in the back. So you have the trachea and you have the esophagus, and there's a piece of skin that comes here, but actually it's a flap, and it's the epiglottis. But actually, I would say that forward-leaning posture actually approximates some ways we protect the airway with a chin tuck. The only thing with that is that the chin tuck is not a good tool for everything. Like hard foods or pills, I don't think a chin tuck is such a great choice. And then also the research shows that the chin tuck doesn't actually work in everybody with Parkinson's or even with other issues. And so it's one of those things where I would definitely only do that after I've worked with a speech therapist, and they would say, you should do the chin tuck and you should not do the chin tuck. Again, kind of taking from the metaphor before, if you are managing food in your mouth and then your head's forward, now all that food may be moving forward, and it's likely to have some, interior spillage, gets out the front door, and the same thing, you're going to have a harder time using gravity to do that. If I got to grab some food here at the end here, I got to really use my tongue to get it out, to get it to the center of my mouth so I can swallow properly. That's difficult. And then again, the lip seal and the air pressure that we were talking about before. Josefa has a great picture here that really highlights this in a more practical way when you're talking about all the other things on the table.
Yeah, lots of things can happen, but decision making and obviously the cognition is coming in strong in terms of, I usually said that the body is trying to find ways to save energy. And so sometimes most people will say that their head goes to the plate or to the fork, or in this case, as you can see in the picture, to the cup, instead of the cup going to the mouth, right? So if I share with you that this lady, she literally has no problem with the arm. I actually suspected because she had recently had a fall, and I was looking at her drink water, and I was like, oh, that's very interesting how she took the decision to put her arm on top of the table and then take her head to the cup and drink like that, right? And so she wasn't aware that this decision was made. This is, again, the brain finds intriguing ways to save energy. And so these things might happen. People are not aware of it. When I show her the picture, I asked her, do you have any issue with your arm? And she told me no. And then she did it normally, right? So it's, I think it's just, it really highlights the need for us to talk about these things, because people are able to change it if they are aware of what they need to change. It's very important for us to remember that it's very hard to remember to keep upright because we are not supposed to remember this. This is supposed to be automatic, right? So how can I remember something that I'm not supposed to be remembering? And that's the unfortunate challenge in Parkinson, where everyone might be telling you have to keep upright, you have to. It's it's exhausting, right? We have to realize that correcting continuously will become really fatiguing. And so we find tips and tricks, and we'll discuss lots of those throughout the session. But this was just an interesting one, just showing the person this happened. Let's be aware of it so that maybe we can avoid it, because there's already a tendency for the person to bend to the side, to the right side. Okay.
Yeah. Yeah. It's a compensation and not one that you were making consciously. It just happened. So that's interesting. Okay. So we talk a little bit about communication and changes related to posture, swallowing and changes related to posture. But we know that a lot of times at meal times, we're communicating. And that's like, I'll say the worst of both worlds. I won't say the worst, but the most difficult of both worlds, in that while you're taking in food and water or liquid, which is really where usually the coughing happens, it's usually the liquids go through the path that leads to resistance and get into the wrong places. You also are supposed to be talking at a volume and keeping up with this. And hopefully you're not a big noisy place where people are walking by and making noise, and that puts you near a room where there's a lot of noise or something like that. And so you have to get around those things. And again, that's why I think one of the easiest things to do is really get your posture in the best position. Not that that's going to solve everything, but at least you're starting with your best foot forward, and you're not starting with a disadvantage. Yeah, the distractibility, boy, I think that's something. And again, Parkinson's happens slowly. It happens insidiously. It's been happening for years. But I look at this as like distractibility in noisy environments. It happens to people as we age. It's more severe in Parkinson's. And so again, one tip for this that we always talk about is just getting into a part of the restaurant where you're maybe in a booth and you don't have people walking right in front of you or right behind you, and it also helps you focus sound. And then also maybe being aware when you're getting ready to talk, to make sure you have a nice upright posture. We'll get into that. We're getting into our treatment here, which is
I would probably even relate it more to fatigue as well, right? So you have the distractibility, makes you use more cognitive resource to try to understand what's going on, because you're filtering other things. And so that can lead to mental fatigue and physical fatigue more quickly, and that will influence your posture to even get worse, right? So there's a snowball that of factors that can influence it.
Yeah. Yeah. But also the flip side of that too, I think, would be that if you can find some techniques, hopefully it will address it at that snowball in that global way as well. Mm-hmm. I want to address it. Somebody said something very interesting, and then I'll also say, someone says drinking from a straw reduces coughing for my husband. And have you hit the third rail in speech language pathology, man? Because straws are terrible because it moves it to the back of your throat. And I was like, yeah, but I see a lot of people doing a straw. I happen to have one right here because I'm drinking some tea. And if we get in a position like this, with your head forward a little bit, your liquid's going to go to the front of your mouth, and gravity's going to actually help you. So if you're doing it right, I don't want to say your name on camera, but if you're doing it right, it could be very helpful. Always check in with your SLP, because there is a possibility for anybody to have what we call silent aspiration, where the lack of sensory awareness in key areas of your swallowing structures means that something can get past your defenses before you know it, and you may not have great sensory awareness of it, so you won't start coughing immediately. But I agree, and I'm saying this as a speech therapist, knowing that there's probably a speech therapist out there that disagrees with me on this, and it's been a long-running battle, but I do think that there's room for it carefully in the right places. But if you do it habitually and you keep yourself upright like this, now your straw is moving the liquid past your natural defenses, which is the back of your tongue. So you have to do it the right way. And again, it's also worth kind of checking in with your SLP. Now, the thing that was very interesting that someone said, and I don't have a great answer here, but I just want to say that I was growing up in Asia and taught to take my mouth to food instead of taking food to mouth to avoid food dropping. And I can absolutely acknowledge a cultural role for the way people might do that. But I would say as we're dealing with Parkinson's, that trying to find food that doesn't put you in a position where you have to be really careful like that, like something that could be coming from we call them scatter consistency, things that break down like rice or something like that. You might try to find ways to eat that so you don't have to do that forward leaning thing, just because it does break down so many other aspects of swallowing or communication, as Josefa was mentioning, managing the table.
But I found that very interesting because I think we all naturally do that. For example, if we're eating soup, although the soups in the US tend to be particularly different from my country, they're all kind of liquid. And so that means we tend to do that. It's natural behavior if you do not want to spill to come forward. What I would suggest in those situations is probably just bring you closer to the table. So that means your effort will be less bending if you do that. But it's keeping in mind, I think in meal times, we should prioritize that it doesn't become a nightmare in terms of all the things that you have to do to be able to have a meal, because that will interfere obviously with your quality of life, right? But keeping what is easy to change, because the goal is for you to be able to get the nutrients that you need, right? So if we start changing too much stuff, I think it will influence our appetite is already influenced, right? So yeah, I tend to look at things with a little bit more flexible mind about how much we really want to change, being realistic that there's so many suggestions and recommendations that all the health professionals will tell you, right? So it's just like, this is meaningful for me, this is impacting me, and I don't believe as a therapist that it's because you bent down a little bit that will be the problem. If you keep in that position, it's more problematic than actually a few minutes that you might be doing that. So
You take care of food or something.
yeah, I think we should be flexible in our recommendations.
Yeah, I can see that point for sure. And just the last part of it, because you were saying something interesting about in Portugal, I find a lot of the soups have been pureed, and they taste a lot like a squash soup over here. Someone had something, or the consistency of a good tomato soup, so it's a little thicker like that. That's actually pretty good for swallowing. It actually helps that a little bit. And I do remember a time when someone made me a soup over there, and they didn't puree it. It looked just like American vegetable soup, and then they pureed it, and it tasted the same. It was great, but it's one of these interesting cultural things. And so, yeah, you might find some ways to expand your palate and make it a little easier
if you need to.
Someone says they do not have a uvula. Does that make swallowing harder? Don't we talk about uvula is that little flap of skin that comes down, and if you I open my mouth, you go you look in the mirror, it'll be the little thing that goes up, It's that it's a little piece there, and you see it in cartoons all the time, right? So I hope we all know what I'm talking about. Not having that, the influence it could have on swallowing, you probably would have encountered more. So we're humans, we adapt. You probably have adapted around it, but it may have an influence on the amount of seal, the amount of closure you have in the back of your throat. So that soft palate, that we call it the velum, that actually, when you're getting ready to swallow, it closes that airway off so it doesn't go out your nose. If someone has nasal regurgitation, they have something coming out of their nose, and we know that that's not sealing all the way. I don't see that very often in Parkinson's. I see that more often in individuals who have had some kind of stroke or something. But it could have an influence. And, one problem with Parkinson's is that if you had something that was a problem like when you were 10 and then you figured your way around it, that is an area of weakness that may crop up later on, and you might need to go back and address it. So if you're having some issues with swallowing, I'll say it again, if you're having swallowing issues, you should get a speech language pathologist, send a message to Sonia and ask her, where to look, and you should work with somebody on that. If you don't see a problem, it's kind of like, if it's not broke, don't fix it kind of thing. All right. Moving into the second half, we're going to talk about our ways to address some of this. I mean, maybe you'll get into some of these questions again when we come back to that. We looked at the surveys, and we were using the same surveys from last month that you guys gave us great information. And these are all the way people are addressing it. So, Josefa,
yeah, so we just wanted to give you a glimpse of basically people that in more the Washington area, right? If I'm saying it right. Expressed, yes, they expressed about how they're handling with the posture, right? So I think nothing surprising. Physiotherapy, obviously exercises, and we will touch upon some of the strategies, but a lot of exercise-based interventions, I would see that. And this was actually one of the reasons why we wanted to do this talk, because we just did last month, sorry. And one focusing specifically on how exercise can help you with posture, but there's a world of other interventions and strategies that people can use. And so I would say this really shows how people are grabbing onto ideas of how I can exercise in order for me to be able to improve, right?
Yeah, there's one thing. Oh, somebody put a list of their therapy teams in the chat, by the way. If anyone's looking for somebody over there, that's great. She's saving the phone call. One thing I noticed here, you have a lot of physical therapy, exercises, occupational therapy, and I believe some tools they're using for that. There are a couple of kind of body awareness techniques. One of them is called Alexander technique, and the other one's called Feldenkrais. And those are kind of things that people would use to kind of understand how their body's working or not working. And I've actually done training in both of them. It's been a while, though. It's back when I was a musician. And particularly Alexander technique was really focused. He was an actor that was dealing with stage fright, and then he would lose his voice, and he figured out there was some positional stuff he can do with that. My only concern about those approaches is that they require an awful lot of cognition. You got to you sit in a very particular way, and you're in this upright posture, and it's correct posture. I have no problem with that, but it requires a lot of cognitive load, where I think it would be smarter to get a trick that you could use, like looking to the sky, like Josefa was saying. And then on top of that, have a physical therapist address any underlying weakness or asymmetry in the muscles, because that will give you long-term relief. So it's not that I'm against these programs or anything like that. I'm just saying, having done some work on, I did Alexander technique for a couple of years. It's very common in the music world. It's an awful lot of, hey, pay attention to this. Now pay attention to that. And while we're here, go here. And as all of a sudden, it's like you're really spending a lot of energy on stuff like that. Okay. Yes. Someone's asked about braces. Good. So again, kind of tying from here, have you, it's one in. Have you gotten guidance? And it's like I said, I'm so happy to see that a lot of people have gotten guidance about posture from the physiotherapist. We do talk about it in a lot of our classes, and in probably some of the classes that you attend in person. It is a shame, though, that all the people that have seen something with a physiotherapist and maybe worked with a trainer or something like that, or somebody that triggers another body awareness movement, equals the amount of people who have not done the work on posture. And I say that there's probably a room for those folks. You ought to consider, again, I don't want to be like looking for problems. If you're not having a problem, it's messing up, your day to day, but bringing it up in a conversation with a physio, you might find some easy things you can do to address it. It might improve your quality very quickly, very helpfully. And then, in your opinion, I'm going to be real careful to read this so I don't go too far ahead of it. But in your opinion, what helps you improve or maintain your better posture? And one is self-awareness and checking your posture in your mirrors or in windows, or receiving reminders from your family members or other people with Parkinson's to keep your awareness. It's nice. If they can call you on it in a way that doesn't become frustrating, that's excellent. That's great. Physical therapy, home exercises, stretching, walking, climbing stairs, Tai Chi. Tai Chi is a very interesting one for balance too. That's nice. And again, I think physical therapy, you should all be having long-term relationships with a physical therapist, and this should be part of that relationship over time. Specific techniques, and this is where the Feldenkrais comes in there. I do like using poles. We use poles for breath work in my classes, and we just did a new exercise today where we took one pole and made it extra long, and I thought that was really helpful. So there's things you can do to work on those chronically shortened muscles to help things. Grasping elbows behind the back, doing stretching and strengthening exercises. Josefa, again, this could be cribbed from your advice. Just taking a break. You'd be surprised what a 30-second break does when you're in the middle of something and you're kind of getting wrapped up in it and you're hyper-focused. It's like just resetting And she mentions this a lot of times when you're out walking and you're getting fatigued. It's like, it's a great bit of advice to just stop for a second, give yourself a break, and then you can reset and be much better.
Yeah, I think the most maybe strange example that I can give you is when the doctor asks you to do this, and what is aiming for is that the amplitude will be lost as you're doing it, as fatigue kicks in. And so if I stop and reset, you will get the amplitude back. Well, by logic, if I'm repeating something, I'm breaking down, the movement is becoming smaller. If I stop and reset, then I can reverse. And this principle can be applied for anything in terms of the symptoms in Parkinson's. So it's worth stopping to think about it. I wanted to come here to a comment that John is putting on here in the chat. I lean over my food because of my right hand that tremors and often leave food on my lips, right? So, which brings me back to a little bit of what I was saying, is that I think there's so many moments that you guys can train and be focused on your posture, that if this happens, I think it helps you have your meal better, right? So it's like, I'm sure that if you are thinking, oh goodness, now I have to stand upright when I'm eating, I honestly wouldn't be passing that message. What I'm saying is, like, be aware of posture in certain moments. There's specific things that we can do that we're just going to cover in a few seconds. But do not become obsessed about it, because there's reasons why we're doing this. There's a reason why that woman bent over to drink that cup. And the reason is that there is a hyper information too much information is going to the right side. So the asymmetry is happening. How am I going to deal that is not by bothering her every time she does it. It's by making her left side stronger, right? So there's ways for me to be able to help her with that problem without being such a nag on that moment. I hope I'm conveying the right message. We want you to work hard on stuff, but we also have to realize that sometimes it's just too much, right? So we're going to give you more examples where you can really work hard at it.
Yeah, no, that's a really good insight, though, is that no one's perfect all the time, and sometimes you might get more satisfactory results just by kind of leaning into the issue for a little bit just to handle that part of it. I will say, if you're dealing with a lot of issues with manipulating foods or something like that, there might be some things you can do adaptively, certainly exercise-wise with an OT. And then also you might be able to pick foods or identify foods that are a little bit easier to eat. We call them finger foods, or things you can use with your hands. And then leaving the food on your lips, again, I think that feels a little bit like a speech therapy question, and maybe worth an bow if you can get to one. I mean, I know where you're coming from. You're in a different part of the country. You don't live in the holy mecca of all the Parkinson's resources that Sonia has aggregated for you in Northern Virginia. So I'll talk to you more about that maybe when I see you in class next time. Your situation's a little different. You all just need to, we're going to clone Sonia and then bring her to your town, and we'll okay, I'll stop, Sonia. I'm sorry. One last thing here, guys, is that people often mention that medications may be helpful and a factor in improving posture, and that should absolutely be the case. When you're on, those meds should be helping you. There's actually lots of things that meds aren't necessarily the primary target. Like, you might notice an improvement in your speech. It's certainly the speed. But the issue is that when you're starting to get to off, that probably you're losing that benefit. DBS will be the same way. It's more consistent. And so, yeah, you might notice some benefits from that for sure. Hopefully it helps. You probably still need to address other specific issues with a little bit of intervention, a little bit of PT or OT. Yes, someone's asked me, can my neurologist refer me to an OT or PT? Absolutely. It'd be great if they had one, like Inova has a number of teams, and they have places they refer when they don't have a team nearby. If you have a doctor that your neurologist has an OT on staff or in their facility, that's perfect, or a PT. Okay, this is interesting. Do you consciously check or correct your posture during the day? And more than a third of you, which is a very good number, pat yourself on the back, several times a day. Half of you are like the rest of us, and maybe sometimes, rarely. Nobody said never. I think that, again, it just speaks to how insidious and common postural issues are in Parkinson's.
Now, I have to share something with you. Mostly in the clinic, who I see complaining most about posture is usually the family. It's something that I think impacts more. Like, for example, we were discussing how I think we should be flexible when we are trying to do a task like eating. But I also have to keep in mind that sometimes it's very relevant for the family that's next to feel comfortable as well, and to have a sense of control of the situation, especially if you're in a social environment. So I want to respect that view as well. And it's mostly, I would say, it's in specific situations where people with Parkinson will actually think about their posture. Remember, it's supposed to be automatic. People that don't have Parkinson are not walking around thinking so much about the posture, even though nowadays, because of our phones, we are thinking more about this. So we are more aware of it. So you can see here in the graphic, what happens is in specific situations, it's really when people are aware of it, right? So when standing up in a long time in the standing position, probably the discomfort of low back pain will kick in and will remind you that something is not right and that probably I have to go rest, right? So the fatigue can bring on discomfort and eventually can bring on pain if you are in a standing position for a long time. Okay, and there's lots of tips and strategies to help you in those situations. If I had to choose one, I would choose opening your feet wider helps you. Like the police do, they usually keep their feet wider when they have to stay in place for a long time. That's how they cope. And then what we see there in the second one, we see when very tired or fatigued. And this is related also to the first one, right? Because it's, if I'm standing in any position, sitting or standing or even lying for long, I will induce strain over my muscles. And so I will have fatigue, right? Fatigue, that's that feeling that I can't really hold that position for longer. So this one would be natural situations where people will be more alert. And then we see when walking, for sure, I think this would be more someone is reminding you, especially in exercise world, people are always training walking. And so they always think about big movements and moving their arms and keeping their posture upright. So this wouldn't surprise me. Less for sitting, but I just highlighted there the most important ones. And obviously, actually, I was expecting this more when I have pain, right? Pain is the ultimate reminder that I'm probably in that position for long periods of time. So thinking of the best solution that I can recommend, and I wouldn't say it's not the easiest one for the person with Parkinson, because nowadays we are getting more and more used to being on cameras and being filmed, because everyone has a phone with a camera. So it's kind of easier. But for many years, I'd be very careful about asking permission if I could do films like this that you're seeing. So as you can see, as I mentioned before, this lady has a tendency to put her objects on the right side. So she's, throughout the day, in any activity that she's doing, she's favoring that side. This is the side of the body where she feels comfortable in moving. So what's the logic behind therapy is me teaching her the opposite, right? So by making these films and then after showing her, we can have a strategy for when she's not in therapy. And I think it's the strongest thing, because I wasn't aware of it. Again, the cup in this situation as well. So I think it's the most effective one, which is really showing with permission, and obviously asking families maybe at home when you think the situation, if the person is on the couch. I usually negotiate this with the person with Parkinson first. I said, you want to ask your wife to film you when you're on the couch, when you're watching TV for a long time, so that we could just assess if that might be the cause of your pain when you're sitting for more than half an hour, right? So it's just finding these things out. And then the other gentleman on the other side is just another example of how the person is on his phone. And when he's on his phone, again, he is shifting all his weight onto his left side, and he's actually even lifting up his right heel, right? So these are the things that physiotherapists are like attentive to. Like, what are the compensating strategies that happen when you are focusing your attention on something else that will influence your posture? And this gentleman was actually complaining of a pain. Guess when? On his left hip, right? So that means excessively being on the left side is generating pain, right? It could be the cause. So how do we treat it? we recognize the problem, and it won't be because even if you went every single day to physiotherapy, I might impact that, but I really need him to check at home in what moments is he, I will call this, not a clinical term, massacrating that left hip. Okay.
Yes.
So just understanding there's lots of things that we can do, but making people aware of the problem, I think, is the best course of action. And then when we think about the world of exercise, I will highly recommend you see the other talk, but just giving you an example of whatever exercise you do, if you do it in a good position, it will help you keep a better posture, right? It will influence your posture outside of that. And the opposite is also valid. So if you are doing exercise in bad posture, that means it's going to negatively impact your capacity to keep your upright posture. Right? So this is important. And how do we do this? So you have different types of ways to do it. I think the best way is to have what I call physical cueing. So you have something tactile that will help you keep that posture. Because just counting on the therapist correcting you continuously, that's verbal cueing, is more challenging. First of all, because unless you're working one-on-one, you won't get that type. And it's very annoying for the person to always be doing that. So if I just create an exercise where I have 2 targets where I'm going to reach, brilliant. I'm keeping my posture upright. No one's annoying me. This is a good amplitude. So this is where you can combine all those exercises that people are saying about the least movement big. I'm just seeing it quickly here. And this program that someone is mentioning in the chat is basically a group, several exercises that are aiming for you to do amplitude, so doing nice movements, and then once you get it nice and big, you do it fast. Okay, so those are the 2 more or less in a very simple way. And the way I think they are done better is if you have these type of cueings that I'm showing here. So for example, if I should do the big movements when I have a wall behind me, that means when I open up my hands, I'm really going to aim to touch the wall, and that means I can guarantee the amplitude. Or else it happens the same thing as I said before. You start repeating and it starts becoming smaller and smaller. So these were just 2 examples. I'm always very optimistic about this. I've seen very severe situations improve. And so never give up on trying to do something because it is possible.
I think there are a lot of ways to address it. So yeah, I do agree. Don't give up. I will say to the person asking about PT, because a neurologist has suggested it to them, someone who's undergone LSVT big training probably does have some familiarity with Parkinson's, and that would be a good start for them. And hopefully they'll have some of the creative ideas Josefa's showing here as well. But it's a good basis. It's a good background. It's a good starting place.
And if you want to know how it looks like, you go on YouTube and you put LSVT big and you will see what you will get.
Yeah.
It's a protocol that's applied usually always the same way in order for it to be called least movement big. So you can actually get a glimpse of it.
Yeah, you need your PT to help tailor it to your actual needs, I think. It's for your work with them. She just mentioned this because this was the lecture before. It's available on the ipmdc.org website under exercise prescription. All of them are there, and they're available, and it talks more about the exercises. Oops. I think this is another one that I like, is having kind of a posture routine. So I remember encountering someone who was working in an office space, and they would say every time they would go to from their office, they would have to pass through this big threshold to go in somewhere, and that was their reminder to kind of reset, and for us to swallow the saliva, because that's usually where I come to the my world. It catches you is you're getting ready to communicate, and you didn't realize you had the saliva, and it's time to talk, and all of a sudden you inhale, and the saliva makes you choke or something like that. So resetting before you would need to communicate, get your point. I'd say when you're sitting down for the first time is a great time to think about it. Again, it's passing through the threshold was someone else's idea, but it worked. And I think anything that you can do, again, there's another one here. Anytime you have an activity where it's limited in time, like brushing your teeth or watching a television, or you're getting a phone call. I got like six spam calls. That only happens when I'm in the States since I've been on this, since I've been here. So if you get a call, you get another reminder, like, okay.
My best tip for when you get a call is don't do it in standing position.
Yeah.
Sit down. And then people usually say, but it's tough to get up. Well, it's exercise if you get up. So people run away from sitting down sometimes, because it does require an effort to get up. That's true. But just be mindful that when you're on the phone, you will be cognitively engaged. And so that will affect your posture. Even if you think it won't, it does, right?
So, okay. Now, another thing that I would normally, this would be exactly where I go, and I love technology. They have made some wearables. I remember doing an analysis of a wearable that was forward position here, you calibrate it in that. And I have to say, I've not tried these personally. That wearable lasted about a day. I almost threw it out of the car. I was driving to Durango to do a presentation. That's back when I lived in Colorado. That's how much I didn't love it. And again, I'm pretty tech friendly. I think it's smart to put something on the back like that. I think that immediately cuts some of the calibration issues. Calibrating meaning it's just a very dumb sensor, so it has to know where you are at. And the problem is that if you're not in that position all the time, if you're in a car or you switch to a different area, the calibration gets thrown off. So I don't have any recommendations on the value of these particular approaches, but you might consider it. Neither of them have been tested on Parkinson's. You got to be watching that. And then one of these people says they're using an adhesive. So it's like a medical adhesive like we would use for someone with like a stoma or something like that. And I would caution you against long-term use of a medical adhesive on your skin in places like there was a device that was here, the Charco, and I'd just be cautious about it because having tape on that part of your body for too long might cause some irritation and breakdown. And that's not just Parkinson's, that's as we all get older. So if you're going to go with one of these tools, get the little pendant and wear it. Someone's asking about the braces before. This was a device called a Bill of Life out of Pittsburgh. She was a very talented designer. And the thing is, when you look at these on the internet, looking in PubMed for research, there are some studies that show they might provide some benefit. They're pretty small. She had managed to get a Medicare code, which is a big deal. It means it can be reimbursed, but only in certain settings. You really have to be able to do. You have to be able to put the orthotic part in there, or it doesn't count, I guess. And so I would say possibly not my first choice unless you have a really serious issue, and only in consultation with your doctor and probably your PT, your healthcare.
The only reason that I would ever suggest such a compensation tool is if you're dealing with pain.
Oh.
Because that, eliminating pain, any strategy goes, right? It's important to realize that once you use them, your brain says, oh, goody, I have something that makes the muscles don't have to work anymore. So the risk and the reason why most physiotherapists might run away from recommending stuff like this is because it's a compensation method, then your other muscles, you must make sure to not stop exercising those muscles the same, or else they might become fragile. But I would say, again, being hopeful that we are able to do a lot to improve posture with lots of strategies, that this would probably be for me a plan Z.
Yep.
This is just another example of things that you might see like online, which is just moments where you really, what does it feel like for me to be upright, right? So it's a funny strategy that I would say I wouldn't walk around with it. I wouldn't make gait training with this. But it's just if the person really wants to, how does it feel to be really upright? But we can move forward.
This is what I would normally see in that little circular cushion ad. Boy, I've seen that a billion times with the OCNPCs.
Yeah, I would say I'm a true believer of changing the environment because there's so many things that people need to deal with Parkinson, that if a good chair, a good strategy helps you deal with 2 or 3 problems, I think that's awesome, right? Because then it's less things that you have to think about. And so these things like choosing well your chair, or adapting this, and you can see an example here on the right. Someone was mentioning, how can I, remind my husband that deals with difficulties in terms of remembering, right? Cognition. And so if you have the positioning, using something like this that will favor his position, it will probably be easier than reminding the person continuously to be upright. So the strategy that I would use would be, how can I change the environment, the chair, I don't know, the place where the person is sitting, sometimes makes the person looks more to the right, and you actually want him to run away from the right. So you might want to put objects on the left, and stuff like that can usually be a good occupational therapist can probably come in and help you make those choices, right? And so I think it's really the best strategies for us to start there to reduce the load of so much that people have to remember.
Agreed. Set up the environment for success rather than saying, hey, while you're at it, remember to do this. And don't forget to, left eyebrow. And it's like, okay, it's a lot. This is, again, not directed towards Parkinson specifically. This was a woman, it's a researcher at Harvard who was showing the benefits of this upright posture seemed to have psychological benefits and cognitive benefits. And what I like about it is these power poses, if you get into that position, you hold them for a little while, it counteracts, this is where the cortisol we were talking about before comes into play. It counteracts some of the kind of evolutionary changes in anxiety levels and feeling strong and secure. And I reread this book over the weekend because I really loved this book. It was a great idea. And she ran into a little trouble with her research, but she came back and redid some of that research and then did a meta study backing her work. But so she came and went, and then she came back, and I'm glad. But it's nothing you can do, and all you're doing is just getting a nice upright posture, and you're holding that. And we do this in our classes when we're doing our basic breath work as we get started. So it's something to help. I want to be cautious. It's not directed towards Parkinson's. I would say if you want to see it, she has a TED Talk that's one of the most popular TED Talks out there. So if you look up Amy Cuddy and TED Talk, I think it's a fun one. It's what got me interested in the topic. Someone's asking, why we're on a substitute chair, what's best for the back? Beanbag chairs, lounging sofa, stiff chair back? What do you recommend, Josefa?
I would recommend getting up every 30 minutes at least. So the chair is true. It makes a difference. It makes a difference in what? In how long you're going to be able to stay in that position. But if you do create this habit of getting up at least half an hour every 30 minutes or so, I've convinced one person to do it, and he was actually suffering from back pain while he was sitting. And he actually engaged with me and did the recommendation, and it really worked out. But it's true that people, we give these recommendations, and it's not easy. Oh my God, I already have to remember to take pills. Now I also have to remember to get up. I don't think there's like a correct answer. I can tell you that the cloth that you choose is very important, because if it's made out of leather, for example, people will tend to, so it can be the most fancy thing ever, but then the material that it's made of cannot be slippery, or else you lose the angle of your feet and your hips. So this is an example of a chair. Maybe next time we can bring you pictures on that. Sofas, obviously by logic, if you actually sit and your knee is slightly above your hip, that will probably keep you in place better. So and the size of the chair should be the size of your thigh. The size of your thigh is probably the reference that you have in terms of how long the seat should be. Hopefully I explained that well, but it's just some tips and tricks that we might think about.
Absolutely. And I think you're smart to think about making sure you have the right chair. I find for working, if I'm in a chair that's not set up for work, I feel it very quickly. Just one last slide, guys, before we open up for any questions. Although we've answered a lot of those, so maybe we've gotten to them, but just a couple things.
Yes, for sure. This is like my favorite picture of all time. So it's when we think about partnership and how families can help. And I went into the waiting room, and I know the gentleman suffers a lot about bending to the right. And I found it adorable that the way the wife handled this was just sitting on his right and pushing him to the left. I must say it's very original. There's lots of strategies that we can tell people, but obviously throughout the day, the context where we are, and the best, I'll say, strategy for, imagine I'm looking at you guys now, and if you are inclined for one side, the best way for us to correct that will not be someone telling you get straight, because you'll probably get until here if you can see me, right? The best way will be to get up and to sit down better. And when I say better, if you are inclining to the right, I will get up and I will exaggerate to the left. So I will sit more on my left buttock, if I say that right, because it will take me longer before I'm there again, right? So these are like tipping tricks that I really hope you will try out, and I hope they really work. It's about, if the person is already in this bad position, trying to push the person to the place is going to be tremendously difficult. It's better to get up and reset, exaggerate to the other side. So you can see there are a list of things, and you'll have access to the slides. It's just for time's sake, probably can't get.
I think too, yeah.
But yeah, I think for there's lots of different tricks that people can use on a daily basis, and just being more aware of and where can I place things, and how can I cue people. Maybe you get a code between each other, families, instead of verbally saying something. I can maybe use a sign when I want to correct in public. You know, you negotiate these tricks. It's like asking, when do you want to be corrected, or how is your posture, is a better question than correcting immediately, because it helps a person maybe gain better ways to assess themselves, and also be more aware of it, how to do it, right? Instead of us immediately jumping on. So I hope you find the summary of some of the tools. It's just, I think movement is a secret to keeping up a good posture, and taking breaks and accepting and recognizing the situations where you think this is going to happen or happens more, and then how can you handle those situations.